and welcome to Rehabilitation Sciences YouTube channel. We are here with a very good lecture today, manual physical therapy techniques for cervical radiculopathy. And we have with us Professor Christian Rimando. We welcome you, sir, on YouTube channel. We would like to have your consent for making your lecture on YouTube live, sir.
Yes, I am fine with it.
Yeah,
I'm giving
thank
my
you so
consent.
much for your consent.
Yes.
And we have moderator today, Dr. Harpreet Singh. He'll formally start the session. Dr. Harpreet, you can start the session, sir.
Yes. A very good evening to all the listeners of Rehabilitation Science Group. Today we have with us Christian Ray Rimando, and he will be presenting on manual therapy for cervical radiculopathy. In brief about Christian, he is an assistant professor at the University of Santo Thomas and is currently teaching at the physical therapy department in the College of Rehabilitation Sciences. He is a specialist in manual therapy and orthopedic clinical practices. He also handles courses in kinesiology and biomechanics. With more than 12 years of clinical and academic experience, we welcome you, sir, today for this presentation, and I hope that people in both the countries will gain from this lecture.
Thank you very much for that very kind introduction. So, good day, everyone. Again, I am Christian Ray Rimando, and I'm a physical therapist from the Philippines. And I am honored and so grateful for this opportunity to share about the manual physical therapy techniques for cervical radiculopathy. So for the disclosure, I would like to declare that there are no conflict of interest in relation to this presentation. So the following are the references used for this presentation, which are mostly systematic reviews and meta-analyses, randomized controlled trials, and other relevant literatures that are already available. So this presentation contains information also based on the actual clinical practice of managing cervical radiculopathy, the techniques that I am also applying to my patients as backed up by these literatures. And as such, I am highlighting in this presentation the evidence-based physical therapy practice. So now, what are we expecting from this presentation? So the objective of this presentation is to present evidence-based manual physical therapy examination, evaluation, assessment, and intervention techniques for cervical radiculopathy. Cervical radiculopathy is a common condition that usually results from compression and irritation of the cervical spinal nerve roots. So for young adults, it is usually caused by disc disorders, disc herniations, and traumatic incidences that could lead to instabilities. Whereas for older adults, it is usually due to disc degeneration and foraminal narrowing, leading to the impingement of the cervical nerve roots. Cervical radiculopathies most frequently affects the C7 and the C6 nerve roots, but other nerve roots might also be affected for this condition. Uh, the literature also found that there's an increased risk when the person has a history of chronic smoking. So for this particular presentation, I will be following the physical therapy patient management model from the examination to evaluation, diagnosis, prognosis, intervention, and outcomes as I try to relate here the manual physical therapy practice. So to begin, it's the examination and evaluation. I'd like to present here a clinical decision-making algorithm that manual physical therapists can use. It's actually a guide that I'm also using in my own practice. So if I'm faced with a patient with cervical radiculopathy, of course, physical therapists, the first thing that we need to do is to screen our patients, especially for any clinical flags. Then that's a time that we decide whether to push through with our PT management or to refer the patient to other professionals before providing our services. So I would like to highlight here that communicating with the other professionals is also one of the best practice that we can employ when dealing with these patients. So once cleared for physical therapy management, maybe that's a time that we can start checking for the subjective assessment and objective assessment to know the reproducible signs, what the patient is feeling, what is the problem of the patient, where is the problem, where is the site of the pain or the problem, and how the patient describes the condition. So I think we're pertaining now to the irritability of the situation. So after that, we can summarize our objective assessment by coming up with a conclusion on whether there's a hypomobility issue or hypermobility issue. In case there's a hypomobility issue, as a physical therapist, we can employ mobilization techniques such as soft tissue, joint, neural mobilization. And if there's an issue on hypermobility or instabilities, as a physical therapist, we can employ stabilization, motor control, or any dynamic exercises. So for this slide, we see that the screening is one of the important phase before we can actually proceed with our PT management. So as part of the history taking, it's very important for us to screen for these red flags in relation to cervical radiculopathy. These are the conditions that we want to check. Cervical myelopathy. We want to check if there's multisegmental weakness, multisegmental sensory changes, neoplastic conditions. So these are the cancer conditions if the patient manifests with night pain. Then we have the upper cervical ligamentous instabilities, which is common for Down syndromes, or if there are any tears in that area. We can also check for vertebral artery insufficiencies, where patients feel dizziness, drop attacks, dysphagia, diplopia, or any inflammatory or systemic diseases. We want to rule that out. And lastly, we have the cervical fracture because there are certain manual therapy techniques that are contraindicated for fractures. So these are the red flags. Aside from the red flags, as a physical therapist, we can also check for the orange flags. The orange clinical flags are for those patients who manifest with clinical depression, those with psychological issues. Together with that are the yellow flags. This is related to the patient's belief and emotions about their conditions. Then for the blue clinical flags, these are the factors that are related to their works, especially when we're talking about the cervical area. Work ergonomics is also one thing that we need to look at for our patients. To continue on with the history taking, one of the most common symptom that the patient will report to us is the pain. So as a physical therapist, we need to quantify it usually by using the visual analog scale, but we need also to qualify it, describe it. What information are we really expecting from our patient? Whether the pain is localized, diffused, or radiating. If we are expecting a radiculopathy, we most likely will be hearing from our patient that it is radiating. So it is suggestive of nerve compromise, particularly if there is a dermatomal pattern that is being presented. And aside from that, knowing that the nerve is affected for this particular condition, we might also hear from our patients that they are suffering from any alterations in the sensation or any muscle weakness. So for this table, it only shows the different neurologic patterns depending on the different cervical nerve roots. So for C4, the pain distribution is usually on this area, on the lower neck and trapezius area. C5 on the lateral arm, C6 dorsolateral arm, C7 on the middle finger, and C8 on the medial forearm, and T1 on the ulnar side of the arm. We need also to qualify the pain by knowing the story of it. What happened to that pain? We need to know the evolution of the severity. Did it start as a mild pain and eventually progress to a severe one? Or maybe some patients will tell you that even from the start, it's the same type of pain that I've been experiencing already. So through that, we will be able to differentiate whether really it is a radiculopathy type of pain or any other conditions. Aside from that, we might want to establish as well the pattern of pain, because some patients will be reporting the pain just on one particular area. Some will say that multiple areas are affected. Some will tell us that it's bilateral in nature. Some will tell us that it's even radiating down to our mid back or even low back area. But for the radiculopathy, cervical radiculopathy, one of the most common pattern that we might be seeing from our patient is the radiation going through the arm. So it's radiating to the upper extremity. So it's very important to establish the relationship of these symptoms, because in reality, multiple symptoms are present for our patients. So the PT must clearly establish if these symptoms are provoked independently from each other, meaning they are not related to each other, or if they are related to each other, they all worsen together. Then another part of the history taking is to determine what activities aggravates the radiating pain, or what activities relieve the radiating pain. We can also ask the patient, will cervical flexion relieve you of that symptom, or will it worsen the symptom? How about extension? How about lateral flexion? How about cervical rotation? And we can also do the multiple movements or the combination of movements. We can also ask the patient whether the symptom is present when we combine extension with lateral flexion or rotation on one side, or whether it is relieved when we're doing flexion, lateral flexion away from the side of symptom, or rotation away from the side of symptom. So that kind of story, if we are taking it from our patient, it will guide us and it will lead us whether the problem is really cervical radiculopathy or not. As a manual therapist, it is also very important for us to establish the irritability of our patient, which is actually a concept raised by Maitland, Jeffrey Maitland, a manual therapist, to characterize the ease with which a condition is exacerbated by the movement. So there are three questions that we need to ask in order to establish the irritability of our patients. So number one, what activities will aggravate the symptom, the radicular symptom? How severe is the pain or the radicular pain? And after cessation of the aggravating movements, how long till the pain returns to the resting level, or will it immediately diminish? And if for most of the for these questions, the patient will tell us that it's too intense, the pain is too intense, most of my activities will aggravate it. It takes a long time before the symptom subsides, then maybe we can classify the patient as highly irritable. But if it's the reverse, then we could conclude that the patient is low irritable. So in order to provide a high standard of care, it's the physical therapist's duty now to refer appropriately cases that are beyond the scope of the practice after doing that, after performing the physical examination, to know the natural history of common disorders and update the knowledge and skills of the physical therapist. So for manual therapy practice, part of the physical examination testing protocol in addressing musculoskeletal and neurologic problem, the PT should look, feel, and move. So later I'll try to expound further on that look, feel, and move. And we need also to check and use other relevant tests such as neurologic tests, provocative and relieving tests, and functional assessments. So the first one is look. As a physical therapist, we perform ocular inspection or visual assessment of our patient. And we also do postural analysis to determine whether there are deviations on the alignment of certain structures. Especially in the cervical region, if the patient presents, for example, with excessive forward-headedness or any other postural deviations there, then there is a big chance that the patient, that's the reason why the patient is suffering from that cervical radiculopathy. Next is feel. As manual PTs, we need to feel the movements of our patients. We feel it through the passive range of motion assessment. We feel it through the end feel after that PROM. We feel it during palpation. So since it involves the cervical spine, we can perform the passive accessory intervertebral motions or the PAVIMs in order to establish whether the segments are hypermobile or hypomobile. It will also help, tell us whether it's just a single affectation of the segment or is it multisegmental, whether it's bilateral or unilateral. Through palpation, we can also palpate for the neighboring structures, such as the muscles, whether they are in the spasm state, or maybe they're already too tight, or maybe they are already presenting with muscle guarding action because of the pain on the area, because they're trying to protect the injured area. Then after the passive movements, we need also to check for the movement or motion of our patients. So here we can use the active range of motion assessment where we can actually further stress at the end range of movement for additional information. So for the neck, maybe we can ask the patient to do repeatedly certain movements that we are assessing. For example, flexion, then flexion again. We want to repeat it, whether the symptom will be the same or not. We can also employ sustained movements of the neck. So we can ask the patient, can you keep your head in that extended position? Let's say for a few seconds, and let's see whether the symptoms will be reproduced or not. Then check for the combined movements. The one that I've been mentioning a while ago. For example, we'll combine flexion with lateral flexion, extension with lateral flexion, and we can combine even some rotational movements of the neck. Then we can also check for the intervertebral motions during the active motion. So by palpating the different segments, as the patient performs flexion, extension, lateral flexion, and rotation, we want to check whether the facet joints are opening or closing during that particular movement. Or maybe sometimes for problematic patients, these joints are not moving at all. Then we can conclude that it's actually hypomobile. Then upon doing all these active movements, we need to check whether the symptom is centralizing or peripheralizing. When we say centralizing, from a distal symptom, it goes to the proximal area. And that's actually a good prognosis if the patient presents with centralization type of symptom. But if the symptom starts off from the proximal area going to the distal area, then we could say that it's already peripheralizing. Then it presents now with a poorer prognosis when it comes to radiculopathy problems. Next, since nerves are affected here, we might want to check also for the muscle strength of the area. We can check for the cervical spine muscle strength. We can check for the upper extremity muscle strength of our patients. So all these things we can also assess and evaluate on our patients. So as a physical therapist, maybe we can use the myotomal pattern for the muscle testing. For example, for C5, we can perform shoulder abduction, C6, elbow flexion with wrist extension, then C7, we have elbow extension, C8, we have the finger flexion, and T1, the finger abduction movements. So this particular slide summarizes the things that we've discussed a while ago. So here it will guide us or lead us as to the tissue that we are actually providing that tension or that stress. So this is the selective tissue tension testing. Just a summary of the ones that I've been explaining a while ago. The evaluation, if we're doing the PROM assessment, then we are actually testing for the inert or non-contractile soft tissues. Um, then for the AROM, we are most likely testing for the contractile soft tissues, and it may also involve the inert structures. And for the resistive assessment, then we can check now for the minor, major contractile structures, and even for the nerves. So aside from the look, feel, and move assessment, we can also perform certain physical examinations such as neurologic tests. So sensory assessment, because nerve subserves both sensory and motor function. That's why we should perform also our sensory assessment, whether it follows a dermatomal pattern. We can also check for the deep tendon reflexes, at which the triceps reflex is most commonly affected for the upper extremity. So if they present with positive radiculopathy, then the result of the reflex testing will be diminished. We can also do provocative and relieving tests. So example of that is the Sperling test, which is highly specific and highly sensitive maneuver um, to determine whether there really is a compression or an impingement of the nerve root in the area. So a positive test for the Sperling's test after providing the downward axial compressive force while the neck is laterally flexed and extended. Take note, when laterally flexed and extended, we are already closing the facet area there. Then by applying that downward force, the more that we are actually compressing and narrowing that space. And if the patient really presents with radiculopathy, then the nerve will be impinged during this maneuver. Therefore, a positive result will now reproduce the radicular symptoms on our patients. Another test is the upper limb tension test, at which we have a different test for the median nerve, ulnar nerve, radial nerve. It is a sensitive test also in ruling out cervical radiculopathy, and a positive result is usually the reproduction of pain at any step of the maneuver because there are a series of movements that we are performing in the upper limb tension test. Next is the cervical traction test. It's actually a relieving test. So a positive cervical traction test will relieve the patient of the symptom because by applying that distractive force from the cervical segments, we are actually freeing the impinged nerve from being compressed. That's why the patient will tell us that the symptoms are actually gone or maybe diminished when we perform that particular test. We need also to perform our functional assessment. So those functional activities that involves neck movement, such as simply turning the head upwards, downwards, or maybe to the sides. So we need also to relate the functions of the nearby regions, such as the jaw or the mandible, and even the upper extremity, the shoulder. So we know that these segments are functionally linked to each other. Therefore, an affectation of one segment might also manifest with functional difficulties on other segments. So usually patients who present with cervical radiculopathy with postural deviations, they might also present with TMJ problem or temporomandibular joint problems, such as the clicking in the TMJ, or some of the patients might also present with shoulder pathologies in relation to that cervical affectation. As a manual physical therapist, it's also very important for us to use the functional outcome measure tools. An example is the Neck Disability Index. This NDI is actually a modification of the OSWES 3 Low Back Pain Index. So this one is very specific now for the neck, at which there are 10 items assessing for the pain and the different functions in order for us to know whether the patient is really affected by this condition or not. Next, we need also to establish our differential diagnosis. We need to differentiate if the radiation or if the pain that's felt on other areas are really radiating pain, radicular pain, or whether they are related to the cardiac pain. Because cardiac pain also presents with referred pain on these areas. We need also to differentiate it from spondylotic myelopathy. However, this particular condition also affects the gait and the balance of our patients. Another differential diagnosis is for the complex regional pain syndrome, the shoulder hand syndrome, which is sympathetic in nature, the entrapment syndromes, which is a localized affectation of the nerve distal to the cervical spine. Another differential diagnosis, herpes zoster, which is the acute inflammation of the dorsal root ganglion, intra and extraspinal tumors, the Parsonage-Turner syndrome, wherein there is an acute onset of proximal upper extremity pain. Then there's the weakness and sensory disturbances. Post-median sternotomy lesions, rotator cuff pathologies, but usually these do not really present with sensory issues. Then thoracic outlet syndrome, there's the associated issues on the vascular, on the different arteries. So now for the clinical reasoning, it involves the diagnosis and the prognosis. For clinical reasoning, it's the process by which the manual physical therapists are already interacting with our patient. We collected the information, we generated our own hypothesis, and now this is the time for us to determine our optimal management for our patients based on the information that we obtained. So for the clinical decision making, we can follow this guide. As a manual physical therapist, we can summarize our approach as evaluation, treatment, and re-evaluation. We evaluate first our patient. We check the inert structures, we check the contractile structures, we check for the neural structures. Then if we see any impairment or problems with these structures, then that's the time that we go to the treatment. So we treat the inert structures by doing soft tissue relaxation techniques, joint mobilization techniques, or joint manipulation techniques. We treat the contractile structures by performing soft tissue relaxation and by improving their motor control. And we treat the neural structures by performing neural mobilization. So after doing this treatment, then we need to re-evaluate the patient immediately after that treatment so that we would know whether the patient reacted well with our treatment or not. Or it will guide us whether we need to do some modifications or not for our treatment. So I think this is a very good thinking, a clinical reasoning thinking for manual therapists. It's a pattern that I actually employ in my own practice. I always follow this principle of evaluate, treat, and re-evaluate so that I know that whatever I'm doing to my patient is actually effective. And if not, then I need to modify my technique. So for manual physical therapy goals in relation to cervical radiculopathy, part of our goal is to release the compressed nerve root. We need to reduce or address the pain and inflammation. We can improve the posture of our patient. We can improve the motion, the range of motion, joint mechanics, and even the strength of our patient. We can improve the body mechanics or even the work ergonomics of our patients. And now for the manual physical therapy interventions and outcomes, I will be presenting it based on the sequence that I usually follow when I apply it to my patients. When I treat a cervical radiculopathy case, usually before I release the nerve, I also check for the structures that are surrounding it. I check if they are affected. I check them whether they are tight or not, whether I need to release them or not. So I usually start with the superficial structures before I proceed to the deeper structures. And we know that the nerve roots are actually deeper already. That's why I usually perform my nerve root release techniques after performing the soft tissue relaxation techniques, after performing any other techniques that are superficial from the nerve roots. So that's the usual sequence that I follow when I perform the manual physical therapy interventions for cervical radiculopathy. I usually begin with soft tissue relaxation techniques. So here I perform muscle energy techniques, and it is usually being followed by the stretching technique of the upper trapezius and the scalenes, wherein I ask the patient to perform the contraction of that particular muscles for around 6 seconds, then repeat that for 3 times so that it will produce its own relaxation. That's the autogenic inhibition. Then once it relaxes, that's a time that I can actually easily stretch that muscle. Next is the cervical traction. So we can apply the mechanical cervical traction where we can use the machines. Based on the literature, there's a significant effect on pain at short and intermediate terms, and it also improves the functional ability of our patient at short-term rate. However, as manual physical therapists, we can also use the manual cervical traction. So according to the literature, manual cervical traction also results to significant effect on pain at short-term period. So these findings are based on the systematic review and meta-analysis by Romeo and his colleagues. Next is the suboccipital inhibition. So we can also relax that particular area by performing the cranial base release or the suboccipital release. So allow me to play this video to show how it's
One
actually
go.
being done.
So now I'll be demonstrating the cranial base release. So for the cranial base release, I will be demonstrating here first what will happen to my fingers later on. So there are just series of steps that I will be performing in order to release the, especially the suboccipital area. So here, for my hands, the first position that I'll be doing is I'll be moving my fingers towards this direction in order to, actually these fingers will be palpating for the suboccipital muscles. Then, afterwards, after doing this position, I will be releasing some of the fibers by moving the fifth and the fourth fingers towards me and the second and the third fingers away from me. So, afterwards, I'll try to supinate my forearms away from each other. This will create further release of the muscles later on. So, then after performing this one, I will be applying more tension to the head by applying the last position. Okay, so those are the series of activities that I'll be doing on the suboccipital muscles. So now, I'll be going on the suboccipital muscles here. So, I'm palpating first for the occiput. I need to locate the muscles beneath it. So, here are the suboccipital muscles. So, at first, I need to apply the first position. So, I need to meld with the muscles when applying this particular technique. So, that's the very important thing here. But the purpose of this video is just to show the different positions. So, I won't really complete the actual process. So, actually, in the actual process, we need to wait for the muscles to relax. Okay? So, before we can proceed to the next step. So this is the first position of my fingers. Then afterwards, I'll be flexing my MCPs and my IPs. Then I will wait for the muscle to relax. So how do I know if the muscle is fully relaxed already? I will be able to feel the head through my palms. So by that time, I know that it's already fully relaxed. Then after performing this position, this is the time that I will be moving away my second and third finger away from the fourth and fifth finger. Remember a while ago? Then again, I'll wait for the muscles to relax here. Then afterwards, I will be fully supinating my forearms. So then I'll wait for the muscles to relax again. So if there's already the release, that's the time that I can proceed to the next step. Then for the final step, I will be positioning the head in the full flexion so that there is the complete release of the suboccipital muscles. So for this particular video, I just presented the different positions.
Okay, so now after showing the different techniques to relax the muscles, I'll be presenting now the different techniques that I usually do to improve the motor control of the deep cervical flexors. So to improve the motor control of the deep cervical flexors, I usually perform the chin nod or the chin tuck exercise. It's actually a fine-tuning postural control in order to activate the deep cervical flexors without producing much contraction of the superficial global muscles of the neck. As much as possible, we want to isolate the deep cervical flexors in order to produce that core stabilization inside. So aside from that, we can also do some postural exercise of scapular retraction. So by improving the posture, we are also correcting the alignment of the cervical region. Before we release later on the nerve root, we must ensure that the alignment is in its proper form so that when we release later on the nerve roots, it won't recur or it will prevent the recurrence of the compression. Another technique is the joint mobilization technique. So here we can do the sustained natural apophyseal glides or the snags. These snags, we actually apply mobilization of the facet joints manually while the patient is actually performing some movements, okay, of the neck. So according to the literature, it's effective in reducing pain and decreasing functional neck mobility. Another possible joint mobilization treatment is the spinal mobilization with arm movement. So I'm applying mobilization force on the facet joints. Then while I'm applying that, we can ask our patient to perform certain shoulder movements. Okay, so that's why it's called the spinal mobilization with arm movement. And the literature also supports that it is effective in reducing the pain and in decreasing the functional neck disability of the patients, based on the study by Shafiq and his colleagues. Next is the cervical spine manipulation. So this particular technique is effective in reducing the pain. So allow me to play this video for the
Go.
cervical spine
So now this is for the
manipulation.
manipulative technique for the cervical region. So for the manipulative technique, we need to assess first the range of motion of the head. So for the assessment, you have to relax, make sure that the patient is relaxed and you are the only one who's moving the head. So just to assess, we'll see the amount of movements that are available. If we will rotate the head here, we can see that it can move as much as this one. But if we can rotate the head here, it's only up to this point. So there's some restrictions that I can feel passively. There's some tension that I can feel now. As compared to this one, we can still move further. Okay? Then when I laterally flex the head, it's only up to this point. And here there's more restrictions. So it seems that the restriction is when we do the lateral flexion to the right and rotation to the right. Okay? So, um, since the restriction is lateral flexion to the right and rotation to the right, so I'll be applying here the manipulative technique. So, here I'll have to look first for the end position. So this is the end position, okay, of the head. And I can feel that there's already the barrier. Then, we can apply that manipulative technique. Yeah, go.
Okay, so the video that you've watched is joint manipulation for the cervical spine. However, we all know that when we perform joint manipulative techniques, there are risks that are associated with it. However, based on the overview of review done by Nielsen and the colleagues, it shows that the numbers here are really, really low. So when it comes to risk, it's not really that common when it comes to spinal manipulation. So just in case, in order for us to protect ourselves, to address the potential risks during the spinal manipulation, I am suggesting that for manual therapists, which I also do in my own practice, we can incorporate the use of the informed consent when performing the cervical spine manipulation or any other manual therapy techniques. So this is just an example that I'm presenting here, an example of an informed consent that an orthopedic manual physical therapist can give the patient when performing cervical spine manipulation to our patients. So now for the neural symptoms, what do you think are the manual physical therapy goals for these neural symptoms? One of the goal of the PT here is to decompress the nerve roots because they are being impinged. And another thing is to mobilize the neural adhesions, especially if the condition is already subacute or chronic in nature. So in order to address that, we can apply the traction exercises a while ago in order to decompress the nerve roots. So for the succeeding slides, we will be addressing the second PT goal here, which is the mobilization of the neural adhesions. How can we mobilize these neural adhesions? By performing the neural mobilization techniques. So according to the literature, the neural mobilization, when we combine it with manual cervical traction, is more effective in decreasing the pain and in decreasing the functional neck disability. And if we ask the patient to perform the neural mobilization by themselves, which is the active version, as compared to the passive version, it seems that based on the study of IUB, they say that the effect of passive neural mobilization is just the same. They yield the same outcome as the active neural mobilization. So looking at that literature, it seems that it doesn't matter whether we do it passively on our patient or we ask them to do it or perform it by themselves. However, in my own practice, if it is the first time that I'm doing it on my patient, I start off with the passive treatment so that I can gauge the reaction of my patient on this particular treatment. Then eventually, if the patient got used to it already, that's a time that I am already using the active neural mobilization. Okay, so now these are the videos for the neural mobilization.
Go. Okay, so for this clip, I will be demonstrating the tension that is being produced on the nerve. So I'll be using this one as my props, as the nerve. So for this particular demonstration, I will be demonstrating the median nerve. So assuming that this is the median nerve, so it passes through, it starts off from the cervical region going to the distal upper extremity. So now, how do we fully apply tension to this median nerve? So we can apply the complete tension by laterally flexing the head contralaterally. Then we can apply shoulder abduction later on up to 110 degrees, full elbow extension, forearm supination, finger and wrist extension. So through this, we are applying now the tension on the nerve. Now, for our patients, usually this nerve is developing some adhesions. So if there is some adhesion that is being formed here, we need to mobilize or to move that adhesion so that it will break down. So in order to break down that adhesion, we need to perform the neural mobilization. So how do we do that? So first, we can do first the sliding mechanism. So in order to perform the sliding mechanism, take note that this is the full tension of the nerve. So what we need to do is just to release some of its tension by flexing the wrist and the fingers while maintaining the head laterally flexed on the other side. So through this, we are releasing some tension. Then in order to do the sliding mechanism, what I will do is I will be extending the finger and wrist and I'll be bending towards the ipsilateral side. So when we perform this exercise, we are actually producing that sliding mechanism of the nerve. Next is we need to apply the full tension of the nerve. So to apply the full tension of the nerve, which is a progression already of the sliders, we need to fully stretch the nerve by applying the contralateral flexion of the head and the extension of the wrist fingers.
Okay, so now that's for the median nerve done actively. Neural mobilization for the median nerve. So next will be the
Go.
passive neural mobilization of the median nerve.
Go.
So now I will be demonstrating the nerve tension mechanism here. So for the nerve tension, we need to evaluate first through the use of the ULTT test or the upper limb tension test. And after doing or performing that upper limb tension test, that's the time that we will be performing the neural mobilization. So for the median nerve, we know that we can perform the ULTT number 1, upper limb tension test number 1. So take note that we need to laterally flex the head to the side. We need to move it to the opposite side. Then we need to depress the shoulder. So I'll be pushing down to depress the shoulder. Then the first thing that I will do is I'll be applying all the components of the ULTT number 1. So I'll make sure that there's the wrist extension, finger extension, forearm supination. Then later on, I will increase the shoulder abduction to 110 degrees. So I'll ask the patient, do you feel anything? Do you feel any symptoms? So none. So now, as you can see, the course of the nerve is also being stretched in this video. So here's the complete ULTT number 1 position. So as you can see, the median nerve is now fully being stretched. So apologies if this is just a makeshift demonstration of the nerve. So I just tried to be resourceful by using whatever I have right now. So here's the stretching of the median nerve for ULTT number 1. Assuming that the patient felt the symptom. So from this point, up to this point, the patient reported the paresthesia. So what do we do now for the neural mobilization? What I will do, the symptom was here. So I will back off a bit. After backing off a bit, I will be performing the neural mobilization here for 10 times. Okay? So after doing it for 10 times, I will be checking again. If the patient will be slowly, I'll be proceeding to the final position of that ULTT. And I'll be checking again if the patient will feel the symptom or not. Okay?
Okay, that's for the passive execution of the neural mobilization for the median nerve. So next is for the ulnar nerve, the passive ulnar nerve tension test.
Go.
So this demonstration is for the neural mobilization for ulnar nerve. So for the neural mobilization of ulnar nerve, remember the ULTT. We just need to perform the ULTT for the ulnar nerve as part of the pre-assessment. So we will be doing an assessment first. By the way, we need to laterally flex the head to the opposite side. we will be depressing the shoulder. So take note, you'll be applying depression on the shoulder. So after applying that, we will increase the shoulder abduction to 110 degrees. Then we're applying a full elbow flexion. Then we have the forearm movement, and the wrist extension, and all the finger extension. So through this, we can ask the patient, so do you feel any paresthesia? If the patient reports yes, where do you feel them? Usually it's on the medial side of the forearm. So now I'll be performing the mobilization. So for example, assuming that the patient felt the symptom here. The patient told me, okay, there's the symptom here. So what I will do, I will back off a bit. Then from this position, I will be performing the neural mobilization for the ulnar nerve. Okay, so just using the parameters of the range of motion. Then afterwards, I need to reassess. So the format is assessment, then treatment, then reassessment. For the reassessment, I'll have to check if the patient will still feel that paresthesia.
Okay, so that's the neural mobilization for the ulnar nerve. Then maybe later on, if the patient learns how to position the different segments, and maybe we can teach the patient the active version of the neural mobilization. That actually ends my presentation. So I hope that you learned from the sharing that I did about cervical radiculopathy, the practice of manual physical therapy in addressing cervical radiculopathy. And just in case you have any questions, you can contact me through this email. So here's my email address, and I would be very glad to answer your questions by sending me an email. So I would like also to take this opportunity to thank the Rehabilitation Science Group for this opportunity to do this sharing about the manual therapy for cervical radiculopathy. Thank you very much and have a nice day, everyone.
Thank you, Christian, for a nice presentation. You started up with the evidence-based practice, and definitely the physio should know when to take patient and when to refer the patient. And then you decided by the things what are the red flags and the yellow flags are there. So first thing with us is we should find out the red flags and the yellow flags, and it means we shouldn't take the patient, we should refer the patient. And then with the centralization and peripheralization phenomenon, you tell up we can come to know through the movement which movement is better for the patient and not. And through the provocative test and your relieving test, we can find it out whether it is the neural peripheral pathy is there or it is any dysfunction is there. And the main part was there, so we should find it out. It is the hypermobility of the joint or the hypomobility. Because if it is the hypomobility is there, then only we should perform. Uh, sir, it was clear, means if there is a hypomobility is there, Christian, but on which vertebra? Sometimes the students feel, okay, it is onto the lower cervical vertebra is there or onto your upper cervical vertebra, and which manipulation technique? Because in the senior persons, okay, they make it, okay, because the students feel there should be some crack sound should be there. So kindly explain of the thing, how to find it out. Is it the upper cervical vertebra is long or the your lower cervical vertebra are long?
Oh yes, thank you for that question. Actually, it's also very important to determine which particular segment of the cervical spine is affected when it comes to cervical radiculopathy. So in order to determine that, we can actually do our segmental assessment. So we can start off with the palpation of each and every facet joints. Maybe we can start off with the um, most cephalad, yeah, most cephalad vertebral segments. Then we go caudal. Though from the cephalad cervical segments, we will individually check the facet joints. Usually what I do, I check it first bilaterally from the top going down. Then after which I perform a unilateral assessment for each and every facet joints so as to compare the right and left whether there really is a hyper or hypomobility on each segment. But aside from that, I also supplement that with the functional movement of the neck at which I am already assessing the entire segments. So aside from that, I also do the PAVIMS or the SNAGs as my assessment. So as I ask my patient to move the neck, for example, if I ask my patient to do some flexion or extension of the neck, what I do, I am also palpating for the facet joints, whether there is really an opening or closing that's happening. For example, when we flex the neck, we expect that the facet joints should open. So I need to confirm whether it's really opening or not. And for example, for cervical extension, we are actually expecting it to close. So I need to check and to palpate whether it's really closing. And usually for these patients with cervical radiculopathy with issues on hypomobility, when they perform the flexion, there is very limited movement that is being palpated because there is very limited opening that's happening there in the facet joints. And that's a time that I will be able to determine which particular segment is actually affected on the cervical region.
And the same thing you have told us a very good way how to mobilize up your median nerve and the ulnar nerve. But there are the different
Yes.
theories there, the sliding theory or the compression theory is there. So sometimes the students find it difficult if we should stretch it or we should just go for the compression. So can you explain it more way how to find it out? Is the we would be requiring of the stretching or the compression?
Okay, so I think it's about the neural mobilization
Yeah,
now.
yeah.
So for the neural mobilization concept, there are actually two concepts that I want to highlight. The nerves, as they move, we have the sliding movement and we have the tension that we are generating on it. So usually when we treat cervical radiculopathy in the early stages, maybe the first thing that we can apply is the sliding principle. So allow me to use again these props that I used in the video. I have it here with
Yeah,
me.
yeah.
So for example, this is the nerve. For the sliding principle, when we try to move the nerve, we are just sliding it against each other so that we are mobilizing the adhesions through the neural sheaths. But when we say tension, at both ends, we are actually applying already the distractive forces. So for early stage of cervical radiculopathy, usually I start off with the sliding mechanism. So that's the time when I said that when it is stretched on the proximal, you have to release it on the distal. Then you try to do it in reverse on each other. But if you want to apply the tension, that's a time that we should stretch it on all the segments that it crosses on. So that's a time that we are laterally flexing away and we are performing the full range of motion of all the segments for that particular ULTT positions.
Thank you, Dr. Kishan, for explaining a with a simple prop how to go for the sliding theory. And we would love you should come further for the taking up the uh, a more detailed discussion onto the neural mobilization because the manual therapy is having a very big area. So we would request you should come again on our channel and discuss the further points because a lot of points are there because in a simple within this 1 hour webinar we couldn't complete up the all manual therapy. So I would request you should come further on the channel and explain all the different techniques for cervical radiculopathy. Thank you, Dr. Kishan, for giving us
Yes,
time.
sure. Thank you very much also, Dr. Shagin. Yes,
Thank you.
definitely.
Thank you, sir. Thank you.